Pontic design. Pontic is a part of fixed partial denture that replaces missing teeth. The pontic must be achieving an aesthetic appearance and preventing tissue irritation. The basal surface of the pontic must be well polished and smooth to preserve the health of the periodontal tissue. Besides that, the basal surface of the pontic should be convex to make a minimum pressure contact with the alveolar ridge. The inflammation of the periodontal tissue is caused by pontic design. There will be several types which are including saddle ridge lab. Saddle ridge lab, it is form a large concave contact with a ridge. It is also called ridge lab because it is overlap the facial and lingual aspect of the ridge. This type of pontic achieve highly aesthetic result if alveolar ridge is free of defect. Phonetic problem and trapping of food is not unexpected because of close adaptation of the gingival aspect of the pontic to the alveolar ridge. But this type, it is less desirable due to inflammation of the residual ridge. Number 2, modified ridge lab. The design gives the illusion of tooth and possess all or nearly or convex surface for ease of cleaning. The convex configuration would allow the dental floss to maintain continuous contact throughout the entire surface and therefore provide thorough plaque removal. Number 3, conical pontic. The conical pontic is rounded with a tip being small in relation to the overall size of the pontic. This is ideally indicated in case of tooth fracture at tissue crest, because of trauma, dental caries, or structural defect. The advantage of conical pontic will be good access for oral hygiene, but it is poor aesthetic, so it indicated in the posterior area where aesthetic is of minimal concern. Number 4, ovate pontic. Ovate pontic, it is used in area of high aesthetic zone. The tissue's contacting segment is blunt rounded and it is set into a concavity in a ridge. Advanced, it is a superior aesthetic, but it is requires surgical preparation. Number 5, sanitary hygienic pontic. The term hygienic is used to describe pontic that have no contact with the edentulous ridge. This pontic design is frequently called sanitary pontic. The hygienic pontic will be achieved the prerequisite for maintaining a healthy periodontium because it does not contact the underlying soft tissue and provide easy access for oral hygiene and to clean the tissue surface of the pontic. But this space below the pontic does not aesthetically pleasing and may affect aesthetic. Thus, it is dictated its use only in the non-aesthetic posterior aspect because the space may be lodged food leading to the tongue habit. So, here the pontic design, appearance, recommended location, advantage, disadvantage, indication, contraindication, and the material that will be used. Occlusal consideration. Traumatic occlusion may lead to radiographical widening of the periodontal ligament space or a pronounced cervical abfraction. It also led to pocket formation, gingival change, and osseous connective tissue destruction. Excessive occlusal force also led to crystal funneling, alteration for occasional bone quality, variation in the appearance of the lamina. Special consideration: restoration of root, restricted tooth. Although The availability of implant therapy has greatly reduced the frequency with which root amputated teeth are saved. Restoration of root resected teeth is still a viable mode of treatment. It is an important concern that will be taken when restoring root resected teeth is the development of appropriate contour for hygienic access. The primary concern is to avoid any excessively heavy concavities of contour that will prevent access. The interproximal area of root amputated and hemisected teeth often presented with a surface concavities on the root trunk. So this area cannot adequately clean with a dental floss because it will bridge across the concavity. So this surface area can be accessed with interdental brush. Splinting. Splint therapy may be applied with a bonded external appliance, intracoronal appliance, or indirect cast restoration to connect multiple teeth with a goal of improving tooth mobility. The most common indication of splint are mobility of teeth that is increasing or that impair patient comfort. Number 2, migration of teeth. And number 3, processes in which multiple abutments are necessary. Before consider the splint, the clinician must identify the etiology of instability. The most common indication to splint mobile teeth is to improve patient comfort and to provide better control to the occlusion. But important note that any inflammation of periodontal ligament supporting tissue must be controlled before making a decision for splint, because inflammation may cause mobility in the presence of normal occlusal force and normal periodontal ligament support. Periodontics endodontics interaction. Periodontics endodontic interaction. Understanding the interaction between endodontics and periodontics is of crucial importance to the clinician because of the challenge frequently in contour in the assessment, diagnosis, treatment and prognosis of combined endodontic periodontal disease. Etiologic factor such as microorganisms, as well as contributing factor such as trauma, root resorption, perforation, fracture and dental malformation play an important role in the development and progression of such disease. Pathway connect endodontic periodontic tissue. There will be anatomical pathway and non-anatomical pathway. Anatomical pathway including apical foramen, accessory canal, and lateral canal. Apical foramen, it is a principal and most direct route of communication between the pulp and the periodontium because bacterial and inflammatory byproduct may exist readily through the apical foramen to cause a periapical pathosis. The apex may also serve as a portal of entry of inflammatory byproduct from deep periodontal pocket to the pulp. Number 2 of anatomical pathway, congenital absence of cementum exposing dentinal tubule. Number 3, developmental groove. While non-anatomical pathway including atrogenic pathway and vertical root fracture. Classification of perioendo lesion. Number 1, based on etiology, diagnosis, treatment and prognosis by Simon, 1972. It is included primary endodontic lesion, primary endodontic lesion with secondary periodontic involvement, primary periodontic lesion, primary periodontic lesion with secondary endodontic involvement, and true combined lesion. Another classification by Grossman, 1991, based on treatment plan. Type 1 require endodontic treatment only. type 2 require periodontic treatment only, and number 3 require endoperio treatment. Classification as recommended by the World Workshop for Classification, 1999. Endodontic periodontal lesion, periodontics endodontic lesion, and combined lesion. Primary endodontic lesion. An acute exacerbation of a chronic apical lesion on a tooth with a necrotic pulp may drain coronally through the periodontal ligament into the gingival sulcus. In reality, however, it would be a sinus tract originating from the pulp that open into the periodontal ligament. For diagnostic purpose, it is imperative to trace the sinus tract by inserting the cadaver cone and exposing one or more radiographs to determine the origin of the lesion. Primary endodontic lesion with secondary periodontic involvement. After a period of time, if this primary endodontic problem remains untreated, it may then become secondarily involved with a periodontal breakdown. Plaque may begin to form at the gingival margin of the sinus tract, which could result in the periodontitis. The pathway of inflammation into the periodontium through apical foramen, accessory, and lateral canal.